We would like to first start by introducing Dr. Ritu Chaudhuri, my senior colleague, specialist in cornea, refractive and glaucoma. She's an alumnus of KEM and Sion Hospital and did a fellowship at University of Kentucky in the United States and then worked at Shroff Hospital for more than 18 years. Now she's happily settled in Goa and we're happy to have her. Dr. Ritu, please start with your talk first.
Thank you. Good afternoon, everybody. I welcome you all to this session of Goa Ophthalmological Association at the AIOS. My talk for today will be glaucoma progression at controlled IOP, what to do. Glaucoma is a chronic progressive optic neuropathy causing retinal ganglion cell death, leading to visual field loss and permanent irreversible blindness. The only modifiable risk factor is increased intraocular pressure, so the treatment is based on IOP reduction to a level where no additional damage takes place. That's the target IOP. Now, we all must have had a patient in our clinic sometime or the other where the IOP is under control, we've reached target intraocular pressure, the patient is compliant, he keeps coming back for regular follow-ups as advised by us, but for some reason we find that the visual fields are worsening and the patient is deteriorating and the glaucoma seems to be progressing. So the question now here is, can glaucoma progress when the IOP is well controlled? Now, for the next 20 minutes, I'm going to walk you through some of what are the other factors other than IOP that we need to look into, and what are we going to do next for this patient. We need to think beyond intraocular pressure. A detailed history is a must. A good clinical evaluation is also a must, and we need to subject this patient to a detailed systemic evaluation as well. We know that POAG is secondary to optic nerve head hypoperfusion as well as autonomic dysfunction. The early manifest glaucoma trial was one of the first RCTs with an untreated control arm, which showed considerable benefits of treatment, which significantly delayed progression. But 45% of patients of the treated group who had an IOP reduction of 25% still showed progression. In the EMGT trial, the treatment reduced the progression risk by half, almost 50%, and the progression risk factors were found to be higher baseline IOP, pseudoexfoliation, bilateral disease, a worse mean deviation on the perimetry, older age group, and those patients who came back with frequent disc hemorrhages. Also, lower systolic blood pressure, lower systolic perfusion pressure, and cardiovascular disease were found to be new predictors for glaucoma progression, suggesting a vascular role. Also, a thinner central corneal thickness was another new factor that was identified. The OAT study, which is the ocular hypertension treatment study, showed that a higher baseline age, a larger vertical cup disc ratio, a worse pattern standard deviation on the fields, and a higher baseline intraocular pressure. These were good predictors for the onset of POAG. And a thinner CCT, less than that of 555 microns, had a threefold risk of POAG compared to those with thicker CCTs. In the collaborative normal tension glaucoma study, 12% of the treated eyes still showed progression in spite of an IOP reduction by 30%. So all this brought us to a conclusion that there are factors independent from IOP leading to progression in normal tension glaucomas. And in this study, the risk factors for progression were identified to be the female sex, those with history of migraine, and those with recurrent disc hemorrhages. So a summary of some of the landmark clinical trials. As you can see here in the OATS study, with a 20% IOP reduction, the treated group 4.5% still progressed. In the EMGT, in spite of a 25% IOP reduction, the 45% of the treated group showed progression. And in the CNTGS study, in spite of a 30% IOP reduction, 18% of the treated group still showed progression. So that brings us to the vascular risk factors. Low blood pressure fluctuations, nocturnal hypotension, low ocular perfusion pressure, and also large diurnal fluctuations were identified to be important vascular risk factors. Now, what is ocular perfusion pressure? It is the difference between IOP and systemic blood pressure. The ocular perfusion pressure was found to be more sensitive to change in blood pressure than to changes in intraocular pressure. So those patients who showed nocturnal hypotension, what we call as the nocturnal dippers, they were found to be progressing at a much faster rate. And a low ocular perfusion pressure of less than 55 showed an increased prevalence and was identified to be an independent risk factor for glaucoma progression. A low diastolic BP, that also causes optic disc hypoperfusion and glaucoma progression. And in the early manifest glaucoma trial and other studies showed that a low diastolic BP would cause a decrease in the perfusion of the optic nerve head and was a risk factor for glaucoma progression. Also, the low diastolic ocular perfusion pressure in the Baltimore eye study, I survey the patients with a diastolic ocular perfusion pressure less than 30 had a 6-fold risk of glaucoma progression. And also in the Barbados eye study and in the Los Angeles Latino eye study, the low diastolic ocular perfusion pressure was found to be an independent risk factor for glaucoma progression. Also, the mean ocular perfusion pressure, if that's on the lower side, then in the Barbados eye study, it revealed that that could be a risk factor for progression. Large diurnal fluctuations were also associated with glaucoma progression, and in the advanced glaucoma interventional study, it revealed long-term IOP fluctuations to be an independent and stronger predictor of visual field progression as compared to even mean IOP. So just to summarize some of the threshold values to minimize glaucoma progression risk in normal tension glaucoma, the diastolic BP should be greater than or equal to 65, and a diastolic BP less than 65 is linked to optic nerve hypoperfusion and increases the glaucoma progression risk. The mean ocular perfusion pressure should be more than or equal to 50, and fluctuations more than 10 millimeters and values below 50 are associated with increased visual field loss, and maintaining the mean ocular perfusion pressure greater than 50 ensures good optic nerve head perfusion. Also, the mean arterial pressure should be more than or equal to 65, and nocturnal mean arterial pressure reductions below 65 have been correlated with worsening of glaucoma, and the safe range was identified to be between 65 and 90 millimeters of mercury. And the nocturnal mean arterial pressure dip should also be less than 20%. So BP reductions of more than 20% from the daytime values should be avoided, as these overdippers, more than 20% fall in IOP at nighttime, they tend to have faster visual field progression. So what happens to the ocular perfusion pressure at night? In the supine position, mostly the intraocular pressure is on the higher side. The blood pressure goes down and hence the perfusion pressure falls. And these patients, glaucoma patients, will show a slow retinal ganglion cell death and progression of glaucoma. So while the patient is sleeping and the ophthalmologist is sleeping, but our disease, glaucoma, is certainly not sleeping at night. In fact, it is progressing at night, and nocturnal IOP is a sleeping giant. This signifies the importance of 24-hour IOP control and the use of medications which are working at night as well and having a 24-hour IOP reduction. Also, there have been studies revealing that sleeping in either the right or the left decubitus position can be harmful for that particular eye. And patients who show unilateral glaucoma progression, one should take a detailed history of head posture during sleep, whether they are constantly sleeping in either of the lateral positions. Also, if the sleep posture is face down, the eyeball is compressed against pillow, and these patients again can have progression, so they may need to use some protective eye shields to prevent the pressure on the optic nerve. Coming to obstructive sleep apnea, is there a relationship between obstructive sleep apnea and glaucoma? Obstructive sleep apnea is a sleep disorder where breathing stops or becomes shallow during sleep. And a severe OSA is when the AHI index is more than 30, and this has shown, it's found to have a high risk for glaucoma progression. So the AHI is the apnea-hypapnea index, and that tells us the number of apneic spells in 1 hour of sleep that the patient has. So less than 5 is normal, and more than 30 is a severe obstructive sleep apnea. So what is happening is there are recurrent, complete or partial interruption of normal breathing because of the upper airway collapse during sleep, causing a decreased ocular perfusion pressure. Episodic obstructive respiratory disturbances cause severe hypoxemia and increased vascular resistance, causing compromised optic nerve head perfusion and glaucomatous optic neuropathy. So when you find patient is having controlled IOP but still progressing, and these patients, they often come back with recurrent disc hemorrhages and visual field deterioration, then such a patient, certainly you must take a sleep history of snoring or sleeping in either one of the lateral positions. Any history of being sleepy and tired during daytime, please send these patients to the pulmonologist for a sleep study. There's also a stop bang questionnaire where S is snoring, T is feeling tired in the daytime, O is if anybody has observed that the patient is stops breathing during sleep, and P is the history of being treated for high blood pressure. Bang is BMI more than 35, age over 50 years, and neck circumference more than 16 inches, and the male gender. These are high risk for OSA. So a high risk for OSA, if the score is between 5 and 8, then you are at a high risk for OSA. So these patients, if you are suspecting, then please send them for a sleep study. CPAP treatment can reduce the sleep deprivation and the oxidative stress and progression of glaucoma in such patients. But the definitive treatment is the ENT surgeon will do a uveopalato-pharyngoplasty, which will help in the OSA as well as in the glaucoma progression. So don't let your breathless night in the form of OSA be associated with blinding sight. That is the progression of NTG. A brief mention on autonomic dysregulation and glaucoma. We know that the autoregulatory mechanisms of the optic nerve is disrupted in glaucoma, and this impaired autoregulation causes the RGC death and glaucoma progression. Primary insult is at the optic nerve head in the form of raised IOP. The RGCs are working at a reduced energy states. They are more susceptible to the secondary insult in the form of the reduced ocular perfusion pressure, and along with the autonomic dysregulation, all this leads to the retinal ganglion cell death. An example of this is the Flammer syndrome, wherein you have primary vascular dysregulation. There is increased response of the blood vessels to cold and emotional stress, resulting in cold hands. And this makes the eye more sensitive to IOP spikes or blood pressure drops, and the patient is more susceptible to NTG. So we are coming back to the original question where we started. Are there any factors other than the IOP that we need to look into, and what are we going to offer to our patient next? So when we find these patients with controlled IOP progressing, we may need to reset the target IOP. Look into the compliance. Maybe the patient is not compliant, skipping drops, or not putting the drops properly, or putting all the drops together, and they're all flowing out and not getting a chance to act. Repeat a gonioscopy. You may be missing angle closure. Definitely check for the corneal thickness, and also a good diurnal variation round the clock 24-hour with a BP monitoring if possible. That will give you a good idea of the nocturnal hypotension patients. Look for obstructive sleep apnea wherever you are suspecting. Also look, you may be having a neurological pathology which you're missing. Take a history of steroid intake in the form of skin ointments or inhaling steroids, and lifestyle habits needs to be explored. Excuse me. So a detailed good history is very important of refractive surgery like LASIK, which could have reduced the corneal thickness. Rule out migraine, Raynaud's, Flammer syndrome. Check for low BP. A night dose of antihypertensive may be causing nocturnal hypotension. Any history of hemodynamic crisis and acute blood loss, and a history of snoring is important. Take a history of head down yoga postures. So Shirshasana, in any of the postures where the head is lower than the heart, you have a twofold increase from baseline IOP. So this can give rise to spikes in IOP in our glaucoma patients, which may show progression, and we really don't know until we take a detailed history. Also, like I mentioned, the history of right or left-sided sleep position, drinking too much water or any form of fluid in one go. A lot of our patients in India, early morning, they like to drink 2 or 3 liters of water. This can cause spikes in IOP. History of excessive smoking or caffeine and steroid use, and a history of wearing tight collar and tie. There was a study in the BJO way back in 2000 where they found that people who have tight collars and ties do have a spike in intraocular pressure, which can lead to glaucoma progression. And last but not the least, a history of the occupation, these trumpet blowers who are using high resistance wind instruments, they are found to have spikes in intraocular pressure while they are using the instrument. And a good detailed examination, a repeat gonioscopy, corneal thickness, to check for pseudoexfoliation or pigment dispersion, disc hemorrhages, and the type of field defect. So you may be having a neurological field defect like seen here, and you need to definitely subject this patient to a neuroimaging. So when do you do neuroimaging? If you have a young patient with unilateral disease, optic disc pallor more than cupping, clinical findings not correlating with the visual field changes, visual field effects not typical of glaucoma like here, when it's respecting the vertical meridian, then you're thinking of neurological causes, or when there is an acute drop in visual acuity, or if the patient has color vision deficiency, then you may think of neurological causes. A detailed systemic evaluation to rule out diabetes, blood pressure, dyslipidemia, cardiovascular disease, any disease requiring long-term steroids. A carotid Doppler may be required in unilateral cases. A sleep study wherever you're suspecting OSA, and an ambulatory blood pressure monitoring, a 24-hour BP monitoring is also very beneficial to pick up the drop and the low IOP, low blood pressure. And an evaluation when you're suspecting migraine or any of those vasospastic diseases. So certain lifestyle changes for glaucoma patients. These patients need to have a good, healthy lifestyle. So regular exercise, which could be walking or jogging or swimming. Have a balanced diet, and herbal supplements like ginkgo biloba extract has been proven to show some antioxidant and neuroprotective properties, and including antioxidants and omega-3 fatty acids in your diet, and quit smoking, avoid headstands, avoid too much caffeine or alcohol, avoid too much water in one go, and weight management, avoid obesity, otherwise you're prone to other lifestyle diseases and obstructive sleep apnea. Stress management, of course, is most important for your overall healthy lifestyle, and stress will increase your endogenous cortisol and again cause a glaucoma progression. A brief mention on meditation and pranayam. So in these patients who are progressing, there's nothing much that we can offer them, and meditation and pranayam has been shown to help with autonomic dysfunction. So slow breathing exercises, wherein less than 6 breaths per minute for 5 minutes in a day, at least 3 times, that is the 3-6-5 breathing, is known to help with autonomic dysfunction. And meditation, it lowers the stress and IOP and diurnal fluctuations in IOP. And mindfulness meditation is a good adjunctive therapy in advanced glaucoma. Small practical tips: repeat the VFA if you're in doubt of progression. Check for compliance. Check IOP in supine position in our office hours. That could give you a good clue of what the nocturnal IOP may be like. Measure ocular perfusion pressure in those with controlled IOP and still progressing. Skip the night dose of antihypertensive if the diastolic blood pressure is less than 65, and avoid topical beta blockers if already on systemic beta blockers. And controlling IOP is the mainstay in glaucoma management, but in those patients who are progressing, in spite of a good IOP control, do look into the vascular factors. A detailed history can sometimes be extremely helpful. And when things are not matching and not correlating, then dig deeper and find those nocturnal dippers. Thank you so much.
Thank you very much, Dr. Ritu, for a very excellent presentation, very comprehensive.